The patient is a 42-year-old woman with a normal BMI. She has a PhD and has support from her husband, making her recovery favorable. She's employed, which is a positive factor. Healthcare costs for a person with an amputation is estimated to be $500,000 or more. The residual limb length is medium, giving her an adequate lever arm to use a prosthesis. She also has no other important past medical history. Her religious beliefs may impact the way she views her limb loss, so she may need a psychologist or counselor to assist her in progressing through the stages of grief. We would want to know her previous level of activity, goals, and her functional status. We would also want to know what her home environment is like in order to determine necessary adaptations and what medications she is currently taking to determine possible side effects and contraindications to therapy.
Positive psychosocial factors include being very involved in her religion as well as having family support from her husband at home. Negative psychosocial factors include her medical history of CRPS because it could develop again in her residual limb from pain from the surgery or phantom limb pain. Positive contextual factors include her income level because she will likely have enough resources to see the doctor or PT as much as she needs and to get a prosthesis, being married leading to family support, having a high education level, being small in her height and her weight leading to better usage of the prosthetic limb, and being fairly young. Negative contextual factors include having stairs at home. She will have to learn to maneuver with her amputated limb, navigating campus for work, possible anxiety because of limb loss, and the effect of her religious customs like kneeling.
There are several healthcare providers involved in this patient's care. A prosthetist is skilled in the design, fabrication, and fitting of the future prosthesis and assesses how the patient walks to gather information on his or her prosthetic fitting. A physical therapist performs an evaluation, provides pre- and post-prosthetic therapy, and identifies appropriate discharge location and type of continued rehab. An occupational therapist enables the patient to reach maximum levels of independence. They can assist with transfer training, care, and management of the residual limb, and assist with determining equipment needs. The primary care physician helps with the general medical care before and after the amputation. The surgical team includes a surgeon, physician assistant, nurse practitioner, nurse, and office staff. The surgeon can write prescriptions needed for further care. Recreational therapy provides entertainment and socialization and maintains physical health and well-being. A counselor helps with emotional issues involving limb loss. A psychiatrist can diagnose, treat, and prevent mental, emotional, and behavioral disorders. A chaplain can talk with a patient about spiritual issues involving limb loss. A social worker or case manager teaches the patient about resources available for support. The pharmacist can order and evaluate labs. They will order, modify, and discontinue medications to enhance patient wellness. Pain management helps the patient understand their pain. This includes phantom sensation, phantom pain, or residual limb pain. It also helps to manage chronic pain, surgical pain, and secondary complications.
There are many tests and measures that are important for this patient. First is medical history. Knowing this will give us a better idea for the patient's risk for another amputation, as well as her healing will go. It can also help determine what her level of function will be. Pain is important, including phantom limb pain and phantom limb sensation. We want to look at her incisional pain or phantom limb sensation to get an objective measure of this pain. It is also important to know if they're experiencing any phantom limb pain or sensation so we can address it in our interventions. Anthropometric characteristics are important, like edema, residual limb measures like the length of the residual limb and the circumference, and body weight, height, and composition. This is important for the person trying to get a prosthesis because it is important for the limb to shrink. The height and weight of the person will affect his or her healing and prognosis for prosthetic use because if they are overweight, it will be much more difficult for the person to be a candidate for a prosthesis. Looking at her skin and integument is important, including healing status, incision, draining, sutures, edema, shape, etc. Noting this will help us monitor the incision for any complications. Circulation in both limbs can help determine a risk for another amputation or for wound healing. The condition of the remaining limb is important because it will tell us if the likelihood of another amputation. We want to look at her range of motion and flexibility proximal to the amputation site, including goniometric measurements of the hip and knee on the amputated side. The patient needs full range of motion and flexibility in order to have proper mechanics for movements, including gait. Joint integrity is important for functional movements post-amputation. If the joints above the amputation stiffen up, it will be harder to have the range of motion and flexibility necessary for functional activities. Muscle performance, including manual muscle tests of the knee flexors extensors, hip flexors extensors, abductors, adductors, muscle endurance, muscle power, and upper extremity muscle function, trunk extensors, and flexors are all important. This will help determine if the patient will be able to walk or if they will need to use a wheelchair. It will also affect how their transfers and mobility will be. Upper extremity strength is critical for performing transfers and for mobility during the times that the patient is not using their prosthesis. Motor function is also important to look at as it affects their ability to perform functional activities as well as don and doff of prosthesis and use a wheelchair. Hand function is important for taking on and off a prosthesis and asking if they will be able to use a wheelchair. We also want to look at aerobic capacity, including blood pressure, heart rate, respiratory rate, and perceived exertion. Using a wheelchair and walking with prosthesis expend much more energy than walking with two legs, so it's important to know if the individual is capable of functionally doing these tasks. We want to look at their attention, cognition, and emotion, because the patient needs to be cognitively unimpaired in order to receive a prosthesis. Sensory integrity, including protective sensation, proprioception, and sensation, is important to look at because it will affect their gait as well as their healing. We want to look at their mobility, including transfers and wheelchair use. To be a candidate for a prosthesis, they need to be able to transfer from the bed, chair, toilet, and back independently using a stand pivot transfer, as well as able to sit to stand independently. Balance and sitting in standing is important, again, for the use of a prosthesis. They have to be able to don and doff the prosthesis and then balance with it on. Gait is important to look at, including their use of assistive device, temporal spatial parameters, and their assistance needed. Looking at the amount of assistance someone needs in order to walk and the way they walk can give us a lot of information about their functional strength and endurance, as well as their balance, proprioception, and sensation. Someone's posture can affect their muscle length and lead to contractures, which will impede healing and functional outcomes. We also want to look at their self-care, because the patient needs to complete self-care activities in order to tailor interventions and make goals for them. Community work and integration is the last test and measure, and this is important to help the patient become as independent as possible and help them reintegrate back into society as successfully as possible. There are many outcome measures you can use for a person with an amputation or prosthesis, but I've just listed some of them here on this slide. The amputee mobility predictor is an objective measure to determine the K level, which is used by Medicare. The +M prosthetic limb user survey of mobility is a self-report instrument for measuring mobility of adults with lower limb amputations. It assesses the patient's perceived ability to carry out activities using their lower limb, so we can get a measure of their confidence in their amputated limb and how well they use it. The 2-minute walk test is a measure of the patient's endurance over 2 minutes with a prosthesis. It helps us get a measure of the person's endurance, functional mobility, and gait. The timed up and go assesses mobility, balance, walking ability, and fall risk. The L test is similar to the tug in it assesses basic mobility in people with amputations. The ABC scale is a subjective measure of confidence in performing activities without falling. This measure gives us information about how the patient feels about their balance and how confident they are in not falling down, which is important because being afraid of falling can lead to falls. The Trinity Amputation and Prosthesis Experience Scale examines the psychosocial issues related to adjustment to a prosthetic, specific demands of wearing a prosthetic, and potential sources of maladjustment. This measure gives us information about how the patient is adjusting to their prosthesis, so we have a better idea of their psychological status. This patient is a K level 3. She has the potential for ambulation with variable cadence that is typical of a community ambulator who will be able to function in different environmental conditions. She also is likely to have function enough that using a prosthesis demands.
Our patient has a left transtibial amputation, so the body structure function part of our ICF model looks like this. It really has decreased range of motion, strength, endurance, flexibility of all limbs, as well as the core that could alter the ability to use a prosthesis in the future or to do transfers or to ambulate with a wheelchair. It also includes residual limb shaping of the left lower extremity, incision site healing, and possible presence of phantom limb sensations. Activity limitations for our patient include standing, walking, transfers, cooking, independent ambulation, ascending and descending stairs, and driving. And participation restrictions include attending mosque services and working as a college professor. From our ICF model, the PT problem list includes decreased strength and endurance in the contralateral lower extremity due to immobility, overall decreased balance, residual limb shaping, possible presence of phantom limb sensations, possible impaired strength, endurance, or range of motion of the upper extremities, hindering the ability to perform wheelchair transfers and ambulation, ambulation with and without a prosthesis, decreased range of motion, strength, and endurance of the left lower extremity, integument screening and facilitation of incision adherence, core strength, stair climbing, and finally, transfers with and without the prosthesis.
This patient has a good prognosis to meet physical therapy goals. Expected to fall into the K3 Medicare functional classification level, this patient is likely to achieve more than basic community ambulation. There are many positive prognostic factors for this patient. At 42 years old, this patient is young and will likely have a better adjustment to use of a prosthetic, which can increase her functional abilities. Prior to her amputation, the patient was generally healthy with a normal BMI and a lack of significant medical history other than type 1 complex regional pain syndrome, which can improve her healing time and recovery process. As a college professor, this patient has a high education level, which is associated with improved healthcare outcomes. As a professor, her amputation will not directly hinder her ability to perform her job duties. However, she may need to make some accommodations such as sitting during lectures and finding alternative means to ambulate around the campus in the short term. Her profession is also positive in that she has financial resources for her medical care as well as health insurance coverage. Furthermore, the patient has social support through her husband, who can also provide assistance with care and ADLs at home. Her strong religious beliefs and practices and community support from the mosque she attends will also be beneficial in her rehabilitation process, which can serve as a source of psychological and emotional support. Additionally, the patient underwent a transtibial amputation versus a transfemoral amputation, which has been shown to generally have easier return to prior function and higher functional status post-amputation. Her residual limb is of medium length, which will make it easier to fit into a prosthesis if desired. Factors which may hinder her progress include potential psychological difficulty adjusting to the amputation. It has been suggested that individuals who are younger at the time of their amputation have a more difficult time with developing an adaptive coping process and adjustment to an amputation. Because she is involved in many roles in her family, occupation, and mosque, she may have difficulty and concern for her ability to perform these roles, such as her ability to kneel at the mosque. Due to her occupation, she may have to adapt to numerous types of terrain in order to navigate around campus in addition to her home environment. Furthermore, she developed type 1 complex regional pain syndrome after her ankle fracture, leading to the amputation, so she is at increased risk for repeated instances of chronic pain in her residual limb or other areas. Type 1 complex regional pain syndrome is often associated with emotional and/or behavioral factors, so this will be of concern for this patient. Additionally, the patient may experience body image challenges following the amputation. She is currently taking Vicodin to manage her pain, so pain reduction techniques will be necessary in order to avoid prolonged use and dependency. Because this patient has many more definitive positive indicators for successful rehabilitation than potential barriers, her prognosis for meeting physical therapy goals is good.
Our prosthetic recommendation will include a dynamic response, non-articulated foot, more specifically a K3 Assure with a 5981 L code. This is essentially a carbon fiber walking foot that will allow her to complete her activities of daily living and hobbies as they are not high intensity. The socket will be a patella weight-bearing socket with increased carbon fiber over the patellar tendon and extra space for the popliteal fossa to accommodate increased time in kneeling during mosque. A shuttle lock with a gel liner will also be used to decrease material for increased comfort in kneeling. Ease of donning and doffing and pistoning is not a major concern as the prosthesis is designed in a relatively lightweight fashion.
Therapy will be divided into 2 phases. The first phase is pre-prosthetic training. The 1-week short-term goals for this patient include the following. Patient caregiver will independently demonstrate wrapping of the residual limb within 1 week in order to facilitate residual limb shaping. Patient will propel wheelchair independently 50% of the time when not using crutches for ambulation in 1 week. Patient will independently ambulate a distance of at least 150 feet times 1 using crutches within 1 week. Patient will perform transfers from bed and chair to and from wheelchair with contact guard assist within 4 days. Patient will perform bed mobility rolling from supine to sit independently within 4 days. Patient will display proper technique of skin checks and vocalize importance of integumentary screening in order to decrease probability of infection within 1 week. The 5-week long-term goals for this patient include the following. Patient will perform right single leg stance for at least 30 seconds with no assistance from balance aid within 5 weeks in order to facilitate decreased risk of falls. Patient will demonstrate left knee flexion range of motion of 110 degrees and knee extension of 0 degrees in 5 weeks to aid in ability to ambulate with prosthesis. Patient will demonstrate lower extremity strength of 4+ out of 5 in 5 weeks to aid in ability to ambulate with prosthesis. Patient will be independent with HEP in 5 weeks.
Phase 2 begins when she has the prosthesis, and the 2-week short-term goals post-prosthesis include the following. Patient will independently don and doff prosthesis with no verbal cues within 2 weeks. Patient will demonstrate compliance with prosthetic wearing schedule at least 80% of the time within 2 weeks as demonstrated by a time log. Patient will maintain single leg stance on the left lower extremity with minimal support for 5 seconds within 2 weeks. Patient will transition from sitting on the floor to standing with minimal assistance 4 out of 5 times in 2 weeks. And finally, patient will be independent with HEP in 2 weeks. The 5-week post-prosthesis goals include patient will ascend 10 stairs with 1 handrail and no assist device, leading with a sound leg in a reciprocal stair climb pattern, standby assist, in 5 weeks. Patient will descend 10 stairs with 1 handrail and no assist device, leading with the prosthesis and reciprocal stair climb pattern, contact guard assist in 5 weeks. Patient will independently ambulate 113 meters during the 2-minute walk test with no assisted device in order to facilitate community independence within 5 weeks. Patient will complete the tug in less than 19 seconds and no assisted device to indicate a decrease in fall risk within 5 weeks. Patient will ambulate 100 feet on an uneven surface independently and with no loss of balance 4 out of 5 times in 5 weeks. Patient will ambulate over and around cone obstacles in her path without loss of balance or hitting the objects independently with no assisted device and 80% accuracy in 5 weeks.
Our patient will benefit from physical therapy to help her reach her highest level of function following her amputation throughout the various stages of postoperative care, pre-prosthetic training, and for prosthetic training. This patient falls into the practice pattern 4J, and individuals in this practice pattern are estimated to achieve their anticipated goals and outcomes within 14 to 45 visits during 1 episode of care. After considering the factors specific to this patient that create her good prognosis, such as the fact that her amputation is recent and her current problem list, we estimate that she will benefit from approximately 30 to 40 visits, depending on how she tolerates the new demands of her amputation and the physical therapy interventions. Her plan of care can be divided into 2 sections. The first includes the post-operative and pre-prosthetic phases, and the second will be the prosthetic phase. While in the hospital, her initial plan of care will be focused on her reaching physiological stability and obtaining enough functional capacity to be discharged home. Once she's discharged from the hospital and ready, she will begin the pre-prosthetic phase of her plan of care. This phase is focused on gaining independence in the care of her residual limb, improving her independence in mobility, transfers, and functional activity, and incorporating a home exercise program. After this, she will move into the second and last phase, which is the prosthetic phase of her plan of care, which will focus on helping her reach her highest level of function with the use of a prosthesis. We'll go into more detail of these phases in the next 2 slides. The first phase will encompass the post-operative and pre-prosthetic training, and the interventions in this phase will vary from those that will be performed immediately post-operatively to when the patient is able to participate in more advanced interventions once the state of healing is appropriate. The main goals of this phase will initially be for the patient to begin psychological adjustment, know proper positioning of her limb, begin independence in mobility, and for healing of the residual limb to occur. As these goals are met, the goals will advance to be for the patient to be independent in residual limb care, independent in mobility, transfers, and functional activities, and to demonstrate proper care of the remaining lower extremity and performance of home exercises. The listed interventions are necessary components to help the patient meet these goals. Mobility training is important in this phase to teach the patient how to be independent in bed mobility, such as rolling and scooting, then mobility in a wheelchair, and as the patient tolerates and improves, mobility with crutches. Mobility with crutches will be introduced initially using a swing-through gait. Along with mobility, the patient will need to learn mobility out of the bed. Transfers in this phase will involve practice and instruction on how to transfer to and from various surfaces with increasing levels of independence, with the goal to be for the patient to be fully independent with these transfers. These transfers will include from the bed to chair, from a wheelchair to shower and or toilet, performing transfers with crutches to a chair, and more. Maintaining range of motion of the remaining limb is another important piece of preventing contractures and helping the patient maintain functional range of motion for daily tasks and later on for prosthetic use. Initially, this will be focused on the hip, and then once the incision site is secure, range of motion of the knee will also occur. Strengthening will include the remaining limb, the core, bilateral upper extremities, and the residual limb. It's important to maintain the strength and function of the remaining limbs so that no further independence will be lost. Core strengthening will occur to improve balance and function in sitting, standing, and with general mobility as the patient is adjusting to a change in her center of mass. This may include activities such as bridging over a bolster, single leg bridging, pelvic tilts, partial sit-ups, and quadruped arm and leg lifts. Bilateral upper extremity strengthening is to ensure the patient is safe for mobility activities and to improve her function using assistive devices through activities such as chair press-ups and kneeling push-ups. Lastly, once the residual limb is healed, the hip and knee strengthening in all directions are valuable to help prepare the patient for prosthetic training. Stretching in this phase is focused on prevention of contractures and maintenance of range of motion. Important stretches in this phase could include prone lying, hip flexor stretching to prevent hip flexor contractures, hamstring stretching to prevent knee flexor contractures, and adductor stretches. Lastly, balance and fall prevention is another important piece in helping the patient to meet the goals of this phase. In this phase, this may look like seated balance exercises with a progression from sitting on a stable surface and performing head turns and reaching to sitting on an unstable surface while performing these same activities.
This phase of interventions will be post-prosthesis. The main goal of this phase will be to help the patient adjust to their new prosthesis and promote safety and functionality. The treatment session would start with a warm-up of pre-gait exercises, including double limb stability, knee stability, weight shifts, step-ups, and balance training. Another technique that has been shown to improve stride length, stride width, and step length is lower extremity PNF. Then, using parallel bars, we would progress to gait training in a closed environment. We would eventually progress to overground closed and open environments, and possibly the treadmill. Reciprocal stepping, stepping over objects, walking backwards and sideways, stopping and starting, changes in direction and speed will all be utilized. Verbal and tactile cues will also be used as needed to ensure proper gait mechanics. Visual cueing by video camera could also provide feedback to the patient. Stair training would include ascending and descending stairs, starting with upper extremity support in a closed environment and progressing from there. It will be important to ensure the full instep of the prosthesis is on the stair to prevent rupture while ascending, and weight should be directly over the heel of the prosthetic foot on the stair while descending. The patient will go up with the intact limb and down with the intact limb. Patient education will continue to be vital during this phase to ensure they are donning and doffing the prosthetic correctly and without wrinkles to protect the skin. Education on sock ply to improve fit and reevaluation as necessary at 10 to 15 ply socks. They will also need to be educated on areas of increased pressure and necessity for early intervention if pressure buildup is noted. Desensitization and mirror therapy will also be given for phantom limb pain if needed. The patient will also complete an HEP using the Wii Fit of 30 minutes for 5 times a week. This includes yoga, balance games, strength, and endurance training, which has been shown to increase walking capacity by the 2-minute walk test and quality of life when combined with traditional physical therapy.
In 1 week, this patient is expected to discharge to home from inpatient rehab with the support and care of her husband. She will receive home health physical therapy followed by outpatient physical therapy when able to mobilize from her home to the clinic. In addition to outpatient physical therapy, the care of a multidisciplinary healthcare team will continue to be utilized. Referral to a prosthetist will be ordered in order to prepare the patient for and initiate the prosthetic fitting process. If the patient exhibits symptoms suggestive of a recurrence of type 1 complex regional pain syndrome or pain out of proportion to what would be expected at her stage of healing, a referral to pain management may be indicated given the patient's history of chronic pain. Consultation with a psychologist, social worker, or other mental health care professional may be needed at any phases of her rehab in order to facilitate an adaptive adjustment process. The patient may also benefit from joining an amputee support group for additional social and emotional peer support. Referral to an occupational therapist can help the patient with any strategies, accommodations, or adaptive equipment that she may need in order to perform her work or home responsibilities. Additionally, a recreational therapist may assist this patient in returning to leisure activities.